presents with what looks like it shouldn't be aggressive, either what we call low risk or intermediate risk prostate cancer, how do we decide if it's safe not to do anything? And the GPS assay was designed to answer that question, to help answer that question. And that's all been validated scientifically. Yes, it does do that. It does predict for aggressive behavior or not at the time of biopsy. And then another question is, okay, so can it actually help drive decision making then? You know, do people use it? And if they use it, is it being used appropriately? Are patients being put on active surveillance based on the test scores and other things? And that's what this study was designed to look at. We looked at all sorts of different descriptors, of men who were, let's say, newly presenting with earlier stage prostate cancer, not metastatic disease, not highly aggressive advanced disease, but the kind that could get, let's say, surgery or radiation or something called focal treatment or hormone treatment, or potentially could get active surveillance of all those kind of men who got the GPS test and then look and see what treatments they got if they did get the GPS test. And did they get active surveillance based on those results, or did they get definitive treatment, what we call surgery or radiation or other kinds of treatments I mentioned? There's other ways that we try to decide what's appropriate for people without a genomic test. There are just clinical characteristics. And so things like your age, your PSA blood test score, the grade of the cancer, which means how it looks under the microscope, how the cells look. There's a score that can be given. The stage of the cancer. So all of these things can be put into risk categories clinically. Looking at that, and what are the NCCN risk stratification scores for these same men in this study, what was done. What you might expect is, and based on guidelines from the NCCN, if you have very low risk prostate cancer based on your clinical characteristics, you should probably be getting active surveillance. And the vast majority of men with the NCCN low risk were put on active surveillance. That's what we observed. If you have NCCN low risk, which is just a little bit more aggressive, let's say, than very low risk, maybe the PSA score is a little higher, the clinical stage is a little higher. The guideline also suggests you should be on active surveillance because those men are also very unlikely to die from prostate cancer or progress very quickly. And with a good active surveillance program, by the way, you follow people and you see if they do progress, you're watching in time and you can change the plan. And that's the purpose of the surveillance. You're not just saying goodbye to people. It's a treatment actually, but it's a careful observation treatment. Anyway, and majority of men with NCCN low risk were put on active surveillance, maybe a little bit less than if you had very low risk. And the same went for intermediate risk cancer. At that point, you're down to about 50% of the men being put on surveillance. And again, that's probably appropriate. And so just using our clinical characteristics and NCCN risk scores, people had appropriate levels of aggressive intervention versus active surveillance. Genomic scoring can really augment what the clinical characteristics can do. Just take, for example, somebody with low-risk prostate cancer on the surface, just looking at what the cells look like under the microscope, what the PSA score is, and what the clinical stage is. And most of these are clinical stage 1 anyway, so it doesn't really tell you that much. But the genetic makeup, the genomic score itself, can show you that there's a dramatic variation in people who look like they have low-risk prostate cancer. And those same people might have a score as low as 0 or a score as high as 60 on the GPS. Every 20 points of GPS score doubles or triples your risk for progression and to be moving on to higher risk prostate cancer. And so if you have a higher GPS score, you probably should have a more aggressive treatment. At least it predicts for a more aggressive cancer. And so If you understand that and your physician understands that, then it's much more likely that the decision towards a definitive treatment is going to be made versus an active surveillance at the time of having that information. And that's also what we saw. So looking at those GPS scores of men who had them, a very low GPS score had a high association of active surveillance. And as the GPS score went up above 40 points, and we broke it down into groups of less than 20 points, 20 to 40, and greater than 40. And for example, patients with greater than 40-point GPS, also about half of them went on to an active treatment as opposed to a surveillance. And so it's confirmed and validated that the scores were being used appropriately, and that when they were obtained, um, the sort of expected treatments were being administered. And maybe the most interesting thing to me was when you combine these things. So the NCCN group alone, we saw appropriate patterns of surveillance versus treatment. The GPS scores alone, similarly, not exactly the same numbers, but similar trends in the right directions. When you combine them, it got really interesting. And so, like I was saying, if you look at just low risk patients, they all look the same. And overall, there's going to be a certain percent of patients who are put on surveillance versus direct treatment. But when you stratify one of those groups, like let's just say low risk, and you break it down into low risk patients who had GPS score less than 20, 20 to 40, and greater than 40, you see appropriate distribution. And so low risk patients with a GPS less than 20, the vast majority are put on surveillance. But that same population of low risk who had a GPS score of greater than 40, at least half of them were being put on treatment appropriately. So it can really help you dive deeper into appropriate treatments and understanding of the cancer aggressiveness within these risk groups. And that is what our study was able to show and confirm. We did not have access to data on outcomes. And so, what happened to these patients 10 years after they had surveillance versus surgery, as an example, we didn't look at that. So I couldn't tell you. Mostly the study was just looking at appropriate use and how using the GPS assay can help physicians and patients with appropriate decision making, and kind of confirm that seems to be happening in this data set in real world, which was great to see. And so no long-term outcome descriptions were looked at for the purposes of this study. I will say that costs were looked at because that kind of data was available due to large claims database and insurance information in this large data set we used. We had some of that information, and it is well known that putting patients on active surveillance is going to be, at least in the short term, a lot less expensive than putting somebody through surgery or radiation. And while you can argue about specific details of costs, and that's going to depend on specific insurance companies and regions of the country, for example, anyway, and specific details of the treatments. In general, what you expect to see is active surveillance being far less expensive. We also confirmed that, and in our study, we found that patients who underwent direct treatments for prostate cancer had costs that were 5 to 6 times as expensive as active surveillance treatment. What we're trying to do is drive the appropriate decision making on an individualized, almost personalized basis for patients, because prostate cancer can be such a big decision and a big impact on lives. We want to be incredibly intentional and careful in providing the right decisions. And the more often we can offer appropriate active surveillance to patients, the better.